screening because government monitors the disease progression. And I think that's activities. Also have hypertension. Never measure the blood pressure there. But I need to measure it for.
Well, I have some of the articles about manifest cardiovascular disease, or coronary disease, and maybe after myocardial infarction. And guidelines say that if you statins, then you get this patient also falls in the high group, in the risk group, for example, based on the HOPE study. So you get insulin, you get aspirin. So what makes the difference?
The heart attack, because there are responders and non-responders within that. It's positive. We're giving monitoring the calcium over time will define benefit of therapy. There isn't that much data about it. Whatever data there is suggests that most patients who progress more than a certain amount, more than 50% per year, have a much worse prognosis than those patients whose plateau stays the same. Well, found that progression is not a number. Correct. There just doesn't whatever level of calcium you start, whether it's starting with the little or starting with the lot. This is data that Leslie Chard has shown with Colorado and just published in 18. That's most missing data. But even vision, all those are off, you don't really know. But still, it's the EBT, that's the best you can do. You can't predict it all just because you change the LDL, just because you got the LDL from 170 to 70. There's no relationship. Unlike the correlations with IVIS and with ILT, which show statistically in a large group of patients that there is less progression in those patients who have lower. And I do the same thing. You can't do it to track the effects of one therapy versus another necessarily to show that one is superior. What we can do in patients is to say, gee, if they progress more than a certain amount, they're in trouble. If they have not progressed, they're in less trouble.
And I don't think that actually the endothelial function is a very good guide to regression of disease. I think endothelial dysfunction is a marker for a high-risk population that needs aggressive therapy. The aggressive therapy slows the progression of disease but does not necessarily restore endothelial function.
That's a good example. Endothelial function exactly what you're arguing with diabetes studies, so that we're going to listen to endothelial function, but the endothelial function will not improve after the first year. But it's like a acute change in the endothelial function, but that's what we're listening to the study. So you shouldn't look at just the acute, but against that, we went back and looked at the outcome model, and they found that in me, the endothelial function in second and third evaluation, I'm talking about EBT was only for chronic prevention patients, not for patients who have established disease. And there is no data that I'm aware of for coronary T showing that there's any prognostic implication to change the outcome implications to change the coronary T over time. There's correlation with plaque, with therapy, but not with outcomes. There's no data shows that if you have less INT progression, you have better prognosis. That was the case. This is coronary changes in INT, which changes in their drugs. They know beyond. This is in the diagnostic plan. This means that you do not recruit people.
I mean, that is reviewed in the supplement.
We're talking about chronic effects. So if somebody continues that's 50% of the calcium, they don't do very well. Correct. But for any of those patients, we want to know, with all this done now, all these drugs, you can say that you have to cost more than a certain amount. There is a likelihood that you're part of the group prevent it as well, but you can't say definitely when you make any individual patient with any test that we know. I know. We've had an argument against actually repeating the test to monitor. This is becoming a culture. That's why. The clinical situation that you're in after, let's say, 3 years of intensive statin therapy, blood pressure reduction, then he says, well, how much calcium is there now, doctor? And then you say, well, there's a little bit more. Well, I mean, he's going to be terribly disappointed that the calcium isn't wrong. I think I read what's on the earlier. This calcium cure for business was saying that we've been talking about putting people in curation therapy to get the calcium away. That's not going to happen. That's what you tell the patient. The first you put it's going to decrease. We think if it increases less, if it increases more, we think it worse off. You explain the trajectory. That is the trajectory associated with an increase or so. Yes. That's why I understand the reasons. Sure. But what do you do if you have one LDL down to 60 and the HDL is 50 and the triglycerides are 50 and the patient still progresses 25% that year? They're probably going to be some trouble if that's a worse prognosis despite the effect of pharmacological therapy of the effect of LDL level. What do we do about it? You measure and perhaps improve that. You attack LDL. You can make slightly more aggressive. Well, we don't know that. But even in an improvement trial, 25% of the patients over time. Patients who say, well, we give up, we can't bring in more. That's what will stimulate a search for things that are further modifiable. Just start over. There's no way for using serious. So I think this was presented with more too long ago this year that wasn't part of the argument presentation, but according to Sarah, we're getting 19 some calcium don't go anywhere. I don't know if they're going to change it. I think some of these slides are there showing about 15% and 25%. That's from the HEV paper. There's a lot of data that put those numbers to be pretty much the same thing. And the number Paolo did with Matt with his data was the same data. Same thing penetrate was 15% per year increase. Had a bigger percent. 80% of AMIs occurred to people had scores 20%. I'm going to show you a slide. Yeah, that was great. Because there are big changes in calcium. Nobody's been able to reproduce this data. This is the journal of reproducible results. Otherwise, it's not. The values around the test. Most of the thoughts of the blind line. But it's kind of different in some of the cases. It was an effective. What do you see? This is twice and this is the supported that people had to have LDLs at least less than 120 before they started to see stabilization. So they're not realistic with what we have learned, but it means that the lower, perhaps better. I mean, so it's not the kind of
there's 3 grams or less of the black side of the
Just studies say that 2/3 of patients who have LDL less than 120 will have plaque regression. There's simply none of them do that. You can remember the chicken. There was some calcium score that we tried to use out because it may be the calcium score, which is a function of density, and it may be that that's actually good. Score or didn't, or that the one that ultimately was, which is our mass score, maybe we didn't. Not to commercial regression, no, that the mass score is a far more universal score, so allow you to take a multi-detector in EBT and at least attempt to bring them to some resolution, which provides some as opposed to right now where they're apples and oranges depending upon what technique you use. So we're trying to link it to these apples and delicious apples and red apples. It is somewhat I think the question is clear now is what have we taught? Reading? 5 years? This is a liver disease, on therapy, I didn't remember what is it. Is going to be accepted. I would say 2 or more. I think 2 and 3. So 2. What are we doing this one? Unfortunately, I appreciate John's point that there's no aggressive therapy you can use, but there's no evidence that any of these therapies to statin and ACE inhibitor and diet and exercise that we all know, if there's anything we can really do that we're sure to justify monitoring the trajectory. Once we've established that the patient has early disease that needs treatment, and we've now initiated therapy, which we know statistically will reduce measurable risk of having an event. Is there any way that we are sure that monitoring will lead to some improvement in management that justifies the cost? I think the answer is no. I think we're going to we can't even get the healthcare agency and the best to do a review also. In a patient with heart failure, the way in which the echo progresses is a marker for a bad outcome, and we have a whole host of therapies that could be not on 7 drugs that could slow progression of disease, and they will not improve a second echo. You get 1 echo on a patient with heart failure, that's it. So to think that you're going to get a second calcium scan without any evidence that you can do anything about, I think you're whistling in the dark here. I don't think it's possible. Let's take what we really know, that we can screen people, can identify disease, and decide who needs to be aggressively treated. We're far from the next stage, I think. But the reality the manager of course of disease that they are to useful for behavioral compliance and so useful for giving patients some feedback to what would be the now asking a different question. Do these tests help to motivate patients to do something? If we're not that the patient should be aggressively treated, then the efforts for compliance become a very different area. But that's an important issue. We should not have the more people
therapy. We need to get pills that are paid for by health insurance so people aren't paying for them themselves and they won't drop off on therapy because they don't want it. They don't want to pay for it. We have to change the perception about why statins are so dangerous that I'm not going to take a statin drug. I mean, that's a perception out there in the community. But this is not our job, I'm afraid. That's really that's a whole host of things.
What's the recommendation? And what's the recommendation come out from the urinary type of recommendation? What recommendation ways to improve the urine?
Because it's more than just a little paragraph. I mean, there's a whole literature on improving compliance and motivating patients and getting them to lose weight and getting them to exercise. And just as bad as that, I mean, look at the literature on weight reduction. How do you get people to lose weight? This enters in.
This for America, to consider as the main show,
repeating this testing in a patient who's already so-called maximally treated is going to help us in guiding therapy, I think goes beyond
and the one thing what the Korea and geography studies show is that almost nothing. There's these 0.15 millimeter changes in credit. And the surprising thing was that the So the bad results of the concept that we were doing were stabilizing cracks to make them less dangerous. That's the whole idea of the practice making it less dangerous. So I would say, I agree with you. I think that repeat action to me at this time, it doesn't seem to be terribly well warranted.
I would agree as well as that would be. I think it belongs in this paragraph saying this is something that is under evaluation or should be considered for future use. We should seek out ways to track the progression of disease as we seek out ways to improve management of elderly on-standing therapy. This is to make it we studied, we did show that many lesions, we know that the exact basis didn't change, but when a much further just actually that handed by also that if you had a good business different paragraph in pursuing procedures. I think we're looking at too much resistance. I think there's not enough data to support it. I do it because intuitively I feel it's the correct thing. The bad things that we should not recommend it. And I think that with Joe said and everybody, I think that's a good way. People who are not treated. And now you need to track them to see whether they now need treatment. That's a different story. Once they're treated with what we view to be optimal therapy, maybe it isn't optimal. Once they're treated, I see there's no rationale, I don't think, in continuing to track those people because we've done the best we can for them. But if you come back on this concept that it's proceeds. There was no point in screening people for early disease until we were convinced that one could slow of disease. So 10 years ago, we didn't know statins would do this. We didn't know ACE inhibitors would do this. What was the point of identifying early disease? There was nothing we could do about it. That was the philosophy. But if you can show that there is now a drug CBE, which when added to existing background therapy slows progression of atherosclerosis, but it's expensive and has a high side effect profile and you don't want to give it to everybody, then filing progression disease is justified because in that select subgroup that are progressing, you might intervene with this expensive, somewhat toxic therapy, which is effective. Then I don't think that
significant in your life. When you go 2 months a year, it's certainly safer than going to the dentist twice a year. So for 2 days, I think it's like 300 milligram or value use the receivers and all that stuff, but it's not per year, and that's what because that's what the radiation workers. That's higher less. And it's another thing we can do instead of going down. But nothing wrong with primarily the questions patient asks, but if I don't have the more, when I have more radiation damage, I think that's a question that patients frequently ask. say resources, because I think this is an option for you can describe the screening part of it, the decision making, and then you can say, okay, resources, and then there's an argument for repeat measure. That's not too difficult. Census data, 45 million, 6 million people in the United States. Let's assume we have excluded criminal benefits,
prevents liable to come from over 65 or 85 and then they exclude people who have or have the disease, about 14 years in the United States for Hodgkin disease. That would be the estimated numbers to your eyes based on the statistics that we have in front of us in those section. Thinking somewhere around what would be the medicine of that? We talked about the US. We have 6 million people, 90 million. I am going to explain how many of them are I think it will be a large representation. What is COVID-19? It's 15 million. So 77 is 15. Is 62. It's a million people. 16 million. For school. We're going to have to say yes. We're going to go to women. 60 million. And use the wellness. Use the wellness. We're having him
Going to make a recommendation that I was wanting to get to that point. You're not going to say EBT by itself. You really are going to have to say calcium usually, or you're going to say EBT or protective CT, and you're going to have to say 60 slices. And you're going to have to be able to pour water. This is something for version 16, because that was something without considered suboptimal, then that might be wrong. If this is a cardiac CT and like their cat, something like what the Alzheimer's license have into the pictures, it's not imaging. So I don't know. I will go up to date or something. I don't know what change to exchange for the fact that it's supported. Let me just take you through this. In the case of the article, we said that this test should be applied, and we call the coronary calcium screening rather than EBQ or NBC to patients who are in the 10 to 20% 10-year risk category, because that is the new recommendation from the American Heart Association. So the so-called intermediate risk group, 10 to 20%, it should be routinely applied in that group. In the lower risk population, only selected subsets like patients with families of premature coronary disease. In the higher risk population, only for those in whom clinical decision was based upon, like a patient refractory to open statins who had persuaded to do it, or a patient who was intolerant of some statin and wanted to give it up. To isolate decision-making in the high-risk population to conform with the AHA statement, because it was really only recommended for intermediate risk. So we wanted to make this mainstream for the general practitioner. So this is what you do with the information, and it applies to those patients who, in the new NCP classification, this chart is literally taken from the new NCP guidelines that just came out. The first 4 rows to the high-risk patient. What we added to it are the calcium scores and percentiles, and the highest risk category at the bottom. So I would not invent the rows, and for drug therapy, the Framingham risk with equivalents, those came from the article. So if the patient has 0 calcium score, they fall into the lower risk Framingham risk equivalent. And again, only for LDL greater than 190. Let's go to the bottom one here. If the patients have a score of 101 to 400 or greater than 75th percentile, they're in the high risk equivalent. So that's straightforward. We created a highest risk category, those who are greater than 400, because we felt it was important to suggest that for these people you should consider ACE inhibitors and beta blockers. Both of those are the same. Optional dose should be less than 70 for both those, because they're both classified as secondary prevention equivalents. One could argue that ACE inhibitors and beta blockers should apply to any score greater than 100. We wouldn't want to be that aggressive.
But why would you bring from the blood pressure and other numbers?
And cardiac reduction in patients who have myocardial infarctions. We're saying these people who have a 4% annual event rate are equivalent to patients who already have myocardial infarction. Yeah, but you should consider the use of ACE inhibitors. Patient population is designed to slow progressive remodeling of the brain ventricle. If you don't have a brain
neutral. I see no rationale for a beta blocker in that population.
Yes. We didn't talk about that. That's a good point. When it comes to risk populations, it used to be simple with the old guidelines. But now they've created this moderate risk and moderately high risk. And so the moderate risk would have been in the past been called lower risk because it's less than 10% for any unattainable risk. So patients that have a calcium score of from 1 to 10 and less than the 75th percentile will be placed in this non-moderate, formerly lower risk category. It's not this that we have to conform with what the new guidelines say. Those patients who have a score between 11 and 100 will be put into the moderately high risk, formerly known as the intermediate risk, 15 to 20% for any unattainable risk category.
Can I just quickly change to our discussion? We started with binary, positive and negative.
Right.
What I need to know, and put up with all those other things that is that, what do you see as the reason of this grading the score from binary to
I think these are the reasonable categories. These are the standard categories that are used to define levels of severity of calcium.
are you saying they're 1 to 10? No, there's standard deviation in different laboratories and different machines. I mean, we see that almost all the time.
This is trivial calcium, 1 to 10, but it's not a level of calcium.
Well, don't you push it too far?
The problem is that people are going to be confronted with nothing sort of 1 is equivalent to sort of 1 million. No, not at all. And I didn't want to run trivial calcium with what we consider moderate calcium. From 0 to 10. The prognostic figures are not for 0 to 10. The prognostic figures are 0, 1 to 10, 10 to 100, 100 to 400, greater than 400. That's following the data. There is no point to that. We have less than 10.
John, when they suggested on this knowledge, I think there's is name. And I think the point we're able to call it now, and when we're able to find it, and when the cover was extensive, I think
essentially crack upon the order to predict the value of the value of a zero score, not a 0 to 10 score.
Okay, now that's a good point. 100,000 people,
the distribution, that will be more than 400.
what's the list of
Age.
about 10% of them are coming to the body in the body.
don't you know?
1%. I want to say.
There's only 1,000 patients here I can collect.
excluding 60% from abortion and aggressive therapy because of lack of disease and correlation and cost effectiveness.
Over the age of 60, what percent are zero? Or do this guy's taking place?
90% of the age 60 is zero. 30%.
30% of men over 60 are still zero.
So, that's actually good. More cost effective. That's right.
And I think we should be emphasizing the value of the zero and the value of the absence of normal elasticity or normal internal thickness. That's a tremendous value in management. So the treatment is much more complicated, but excluding the people who are healthy, it's such a great benefit to the system.
So, like 25,000 people in my lab, is you have the 50, 10, 20, 10, 10. So 50% is zero, and 9% is 9 to 10. So it's a big group. 20%. 10 over 100 and 10 over 400.
This is a study which in 5,000
recommendations who were population-based, not self-referred. One of the fascinating things is that the zero calcium score category, we went over 0.12%, identical to 0.1% in the retrospective self-referred linear chronology. So it really doesn't matter which population we're looking at. Mean calcium, we do 7% linear compared to 0.7% annual per 100. And this is one of the basics for the AHA recommendation. It gives you a 2% period event rate. The 600 in this study gave you a 3.3% event rate. It wasn't updated for 400. It used 600% using it. And the relative risks of the high scores compared to the zero scores are shown here. That's a pretty linear increase. What is the status of that document? It's not going to be able to do by time. But is it a recommendation for the American Heart Association? What you showed before, there would be categories. The recommendation from the American Heart Association is very straightforward. It's just any slow rate on 100 is a secondary risk equivalent. That's the American Heart Association. It's not the NCUA. As the equivalence of the biologic treatment. Interesting. This over here? Yes, this is from the lines that was just made to John. Which is a it's a recommendation of that on that myself. Treatment specific drug levels in this category.